are going to survive longer, no? Yung ating effectiveness ng mga awareness campaigns natin enable our patients to get diagnosed earlier. So ibig sabihin, hopefully, nasa early stages of HIV na sila, and this will make them live longer on effective drugs, and we will encounter issues concerning the aging population soon enough, if not currently. Okay. So, bakit natin kailangang malaman, no? Mas maraming PLHIV ang mabubuhay ng matagal dahil sa effective na gamot. And in a study done in the US and Canada, if you get diagnosed early, for example, at the age of 20 with a high CD4, and you don't have any vices, it was seen that they lived as long as 70 years old. So, medyo nag-equivalent na siya, no, sa mga negative population natin. May mga newly diagnosed din tayo na aged 50 and above. So, dalawang population ito yung mga long-term survivors, tsaka yung diagnosed at a later age. So, when we mention aging, ang definition nito is age 50 and above, whereas pag geriatric, which is a sub-population of the aging population, ito naman po yung 64 and above. Kung maalala nyo, may tayong mga doctors na nag-specialize in geriatric medicine. Ito po yung kanilang mga specific clientele, no? Mga 64 and above. So marami ang posibleng magiging kliyente natin na aging population. Kaso, wala tayong masyadong information about HIV and aging, lalo na sa developing countries tulad natin, no? Hindi natin alam ang sexual beliefs and practices of older people. At that age po ba ay uso ang prevention? Gumagamit ba sila ng condoms, PrEP or PEP na masasabi nating lumiliit yung risk nila for acquiring HIV? Also, in elderly, mas maraming comorbids, no? Mas maraming comorbids, therefore marami silang gamot na kailangan i-take. Therefore, we have to be knowledgeable of the drug interactions of their maintenance medications with their ARVs, yung side effects and affect which can affect adherence of our older PLHIVs, no? Ngayon, so sino ang part ng aging PLHIV? Ang latest na datos natin mula sa January 2023 HARP, sa newly diagnosed 3% lamang ang aged 50 and older. Sa US, ang percentage ng newly diagnosed ng 50 and older ay malaki at about 17%. So we can still say sa Pilipinas, young ang population ng newly diagnosed natin. So paano naman yung mga current, no? Yung mga total PLHIV? Wala tayong readily available na data, pero I'm sure maaari tayo makapag-request sa EB nito. So ang ginawa ko na lang, dahil wala akong time maghintay ng datos mula sa EB, tinignan ko yung sarili kong cohort sa SHIP Clinic, no? Isang clinic lang po ito sa Mandaluyong. And sa aking sariling cohort, 4% ng aking mga pasyente are aged 50 and above. So, mas mataas po yung percentage ko ng aging versus the national population. Sa US, halos kalahati. So, medyo malaki ang kanilang efforts dapat sa pagtugon sa pangailangan ng aging population. Ngayon tayo, whereas now, puro bata ang ating population and medyo nagiging preoccupied pa tayo sa pag-stop ng sobrang taas na new infections, huwag nating kalimutan na sana nasa plano rin ng ating programa ano ang mga pangailangan ng older population at mabibigay ba natin ito. Okay? So, ngayon pa lang, pagplanuhan na natin. So, ito naman yung gusto ko lang i-share na naging history ng age distribution of PLHIV sa US. If you can see, yung yellow bars, ito po yung age distribution noong 2001. So, peak ng kanilang population is about 35 to 39, medyo bata. Tapos yung aging nila at that time ay 10% lang. Pero after 10 years, ang kanilang average or median, no, na age ng PLHIV ay 45 to 49. Di ba? Sabi nga natin, halos kalahati ay aging sa US. Ngayon, nagtanong naman po ako sa aking mga pasyente na aging. Nagpa-survey ako, sabi ko, ano-ano ang concerns mo bilang PLHIV at this age? And surprise, napakadami pa pala ng mga concern. Kinlassify ko sila ukol sa topics na related to their medicine. So, meron pa rin silang mga concern like allergy, sustainability or supply, and effectiveness of the medication. Kasi nag-worry yung iba sa kanila na pag maraming taon ko ba siyang iniinom, nawawalan siya ng bisa. Tapos, of course, yung long-term side effects ng ART. Sa musculoskeletal, I think this is the same concerns din ng mga negative population natin, no? Yung mga arthritis, body pains, madaling mapagod, muscle pains, hindi na siya kasing flexible ng dati, etc. Weight din, as you age, napapansin nila na parang mas mabagal yung metabolism mo, so mas madali ka mag-gain ng weight. Or sa ibang tao naman, ang hirap mag-gain ng weight. One common issue that we all should be concerned with is yung existence of comorbidities na mention din kanina sa ating poll, no? So heart, liver, hypertension, kidney, cholesterol, and diabetes. Some patients also complain of sleep and memory problems in their sexual drive. So, dito pumapasok yung decreased libido, wala silang libog, or erectile dysfunction, hindi na kayang tumayo or tumigas na kanilang ari. Ang social issues hindi din nawawala, no? So, wag nating isipin na porket aging ka na, kumbaga set ka na in life, and retired ka na, okay ka na, hindi pa, no? Andito pa rin yung stigma of the disease. Even after so many years, pinoproblema pa rin nila yun. And there's a fear of how people might respond if they knew. Issues on medical insurance and travel restrictions. So, I'm sure sa mga issues ng social, hindi to nawawala. Pareho din to ng issues ng kahit anong edad. So, let's break it down, no? Itong mga issues ba na to ay mas concern ng PLHIV versus non-PLHIV? Pare-pareho naman tayong tumatanda. So, bottom line, ang PLHIV ay may mas malaking chance na magkaroon ng mga ito. Multiple comorbids, multiple medications, HIV-associated non-AIDS conditions, increased vulnerability to stress, and changes in physical and cognitive abilities. Mas madaling makuha, mas maagang edad makuha. Alaman natin later bakit. So, ito naman ay prevalence, no? Prevalence of comorbidities depende sa age and sex standards. Yung mga black circles ay prevalence nila among PLHIVs, and then yung mga white circles ay among negative. And you can see almost in all types of diseases, mas makikita ang mga comorbids na ito sa PLHIV more than the HIV negative population. At tumataginting dito, syempre ang high blood, cholesterol, diabetes, anemia, lahat na. Okay, lahat na. Kakaunti lamang ang equal prevalence or mas mataas yung prevalence sa HIV negative. Tignan naman natin ang mga cause of death, okay, through the years. Para dito natin malalaman yung, kumbaga, pinaka-main problem ng mga aging populations natin. Sa unang mga dekada ng pag-diagnose pa lang ng HIV, noong mga 1980s, majority of the cause of death then was due to AIDS. Remember, itong panahon na to, wala pa tayong nakikitang gamot, no? So, kumbaga, the natural history of HIV just played out without any intervention. So, ang pinaka-reason of them expiring was AIDS-related. Okay? And then, in the subsequent decade, 1996 to 2004, lumiliit na yung prevalence of AIDS as death, and lumalabas na ngayon ang mga other causes, no, of death. And as you go on through the years, So pumunta tayo sa latest natin na Swiss study noong 2007, halos wala nang namamatay na AIDS ang dahilan dahil we already have effective medications. Okay? Siguro sa Swiss cohort na ito, lahat ng tao ay may access to effective medication and early diagnosis sila. Sa time na to, ang pinaka-main cause of death among PLHIV are now other cancers. No? If you see, it's non-AIDS malignancy. Hindi na related to HIV ang kanilang ikinamamatay. Heart disease na, no? Cancer na hindi HIV related ha. So hindi siya Kaposi, hindi siya lymphoma. Probably it's lung cancer, melanoma, ganyan. So in a way, maganda kasi nakakontrol mo na yung HIV. Pero ngayon, kailangan mas listo na tayo kasi iba na. Ngayon yung kailangan pagtuunan natin ng pansin, no? Okay. So these are the These are the comparisons of typical aging and aging with HIV per organ system. It's very important to at least be familiar with this para ma-compare mo kasi yung bilang tayo as providers, no? Yung pinag-aralan natin during medical school at yung experience natin during training before we found ourselves in the field of HIV is for the general population. So meron tayong mga theories on how disease pathophysiology is supposed to be, but it might be different now if your clientele is mostly HIV. So ito lang siya, no? Iba yung kanyang aging process. Hindi ko na siya i-discuss in detail, pero i-highlight ko lang dito sa vascular diseases kasi ito nga yung most common cause of death natin. In HIV, myocardial infarction and cerebrovascular disease is 50% higher compared to the non-HIV population. So this means that we must be able to recognize, prevent earlier, and provide intervention sa level natin as primary care. Sa atin pa lang. Okay. So ngayon, pag-usapan naman natin ang dahilan kung bakit. So na-establish natin, increased risk ang PLHIV for comorbids, pero bakit? So ito yung mga nilatag nilang mga theory, no? So una, sa ating mga long-term survivors na nagkaroon ng HIV before 1995, sila ay maaaring na-expose sa ating mga legacy drugs na maaari nag-cause ng harmful side effects sa mga organs. Mga legacy drugs kasi natin, na-realize natin na long-term exposure to it may cause, kunyari, increase deposition of cholesterol in the blood or can cause higher incidence of heart disease. Kaya nililipat natin ngayon, di ba, yung mga gamot mula sa mga makaluma papunta sa isang gamot na hindi lamang madaling i-take pero less ang side effect. Pero sa mga long-term survivors natin, the damage has already been done. Okay. Pangalawa, ang hindi pag-inom ng gamot ng madalas ay nag-i-increase ng proseso ng inflammation which the PLHIV already has. Okay. More on that later. Pangatlo, some of our PLHIV population may have other social factors which cause them to have less access to good nutrition, have not an ideal lifestyle, and the existence of health disparity or lack of access. Pang-apat, maaring may exposure din ang PLHIV sa substance abuse, smoking rates, and other co-infections. And all of these tie up the increased risk for comorbidities. Okay, so the risk of having comorbidities increases as individuals go older. HIV itself does not cause this illness. However, the underlying reasons for HIV may increase the risk, aside from the risk added by the medication. So example lang example. pag ang isang pasyente ko, kunyari, ay nagkaroon ng problema sa kolesterol, at tinatanong niya, Dok, bakit ako mataas ang kolesterol ko? 20 lang ako. So, ine-explain ko na maliban sa diet natin, baka mayroon tayong familiar factors o genetics. Pangalawa, yung underlying condition mo na HIV is a chronic inflammatory condition that increases cholesterol, plus may exposure ka sa gamot na maaaring makadagdag na to. So, there's an interplay of multiple factors that cause a certain condition. Hindi mo pwedeng sisihin yung isang bagay lamang, kaya kailangan mong i-address din siya lahat. And same goes with aging. These are the underlying conditions na sinabi natin na nagko-contribute sa increased comorbidities, no? Simulan natin dito. So, a low CD4 count at diagnosis and currently co-infections, exposure to ART, aging itself, lifestyle, and persistent inflammation. Itong persistent inflammation is a common theme that is seen, no, in all literature when they mention aging, and this is how it happens. So, in someone who has HIV infection, there will be inflammation, pamamaga, and immune activation. Ang pagbigay ng ART ay hindi nagpipigil sa inflammation and immune activation na nangyayari sa katawan. Even with an undetectable viral load, there still exists some low-level viremia plus other molecular factors that produces this chronic inflammatory condition. Okay? And ito siya, no? So, ito yung proximal effect niya. So, ito yung, ano ba yung inflammation? So, meron tayong monocyte and macrophage activation, which alters your coagulation and whatever other processes there are. And how will it manifest? Anong mangyayari kung may inflammation ka nga? Ito yun. Pwede ka magkaroon ng atherosclerosis or pag-deposit ng cholesterol sa mga vessels, vascular dysfunction, and tissue necrosis. Yun yung effect nila. And ito yung nagkakos ngayon ng multimorbidities and the aging process. So it's because of the infection with HIV. Okay? So ito yung iba pa na mechanism of aging na postulate ng mga investigator, no? So ito yung altered intracellular communication due to inflammation and lack of immune regulation, genomic damage, other technical terms, no? So this occurs in the molecular level. And then it is evidenced in the population by having increased lipopolysaccharide amount in the blood, no? So nakita nila na it's highest in those with HIV who are untreated. It is high still in HIV positive, even if they have ART, because it is not equivalent to those who do not have HIV. So kumbaga, ART will decrease the inflammation, but it's not totally pre-HIV levels. Okay? So, meron pa rin tayong risk dahil doon. And because of this inflammatory process wherein na overactivate yung mga immune cells na katawan ng mga PLHIV, nagkakaroon siya ng state of exhaustion. Napapagod siya. Takbo siyang takbo eh. And this is called inflammaging. Okay? Alright, so dahil alam na natin ngayon bakit mas at risk for comorbidities ang PLHIV, alamin naman natin ano ang pwede natin gawin. Okay, so ito na nga, the risk is there. So how do we address it? So una, for HIV positive patients with cardiovascular risk, they should be managed with aggressive primary prevention. How? Control the BP. So, unang tanong, nagbi-BP ba tayo? Okay. Parang dapat basic yun sa atin, di ba? Patients must know what their usual and highest BP are. Ngayon, factoring the effect of white coat hypertension or tumataas lang yung BP sa clinic, no? Pero pag sa bahay normal, i-factor natin yon. So, kung mataas siya lagi sa clinic, tanungin natin, pag sa bahay ka, pag relax ka, ano yung usual BP mo? And that will give us, kumbaga, a better image. And if we find out that it's still elevated, let us control it ourselves as the primary care providers of the patients. Lipids, nag-check mo tayo ng cholesterol at least once a year, okay? Kahit I think it's in our guidelines, no, that we must check our patients' cholesterol once a year. Kasi ang dami, I tell you guys, ang dami kong pasyenteng mataas ang cholesterol na ang babata. And some of them already have NAFLD or non-alcoholic fatty liver disease. If you don't recognize it and treat it adequately, baka magkaroon tayo ng problems in the future. Smoking. So we wanna ask them about their smoking habits and nudge them into quitting, because in PLHIV, lung cancer is still the top, okay? The top cancer, and it is most often from smoking. Let's also recognize a wider array of cardiac conditions like heart failure, arrhythmias, and be knowledgeable of drug-drug interactions. Lalo na kung sa cholesterol, ay magpre-prescribe ka ng statins, alamin mo kung ang pasyente mo ba ay naka-lopinavir, ritonavir. So, anong statin lang ang pwede mo ibigay? Kasi may drug interaction yan. So, sa mga PLHIV, kailangan wag kampante, wag din magpanic, no? So, hindi siya emergency, pero it helps to be conscious and prepare for our 6th and 7th decade, no? Start treatment early for comorbids and take it consistently, and maging health conscious tayo sa ating lifestyle. For at-risk elderly, be mindful. And for providers and supporters, dapat mas marami sana tayong resources, no? Sana mas marami tayong venues for learning about aging. Sana mas marami ring programa at may research para i-control na tong inflammation na nangyayari sa katawan ng HIV. Okay. There are some manifestations of aging which may be non-specific, and minsan baka ma-dismiss lang natin as age-related. So, ito yung mga yon, no? Forgetfulness, difficulty sleeping, fatigue, muscle pain or joint pain, lack of appetite, weight loss, and recurrent pneumonia. So, harinawa ay itong mga clinical presentations na to ay investigatin natin dahil maaring cardiac pala sila, no? Lalo na kapag matanda na. So, one way to prevent this irony is magkaroon tayo ng routine screening. Gaya na sinabi ko, sana meron tayong annual na lipid profile sa mga pasyente natin, and then when they reach the age of 40, magpa-ECG na tayo, ganun. Okay? So, yung mga pwede nating gawin ngayon ay alamin ang mga side effects ng mga ART natin and tignan kung meron tayo nito sa mga pasyente natin. So, that's one. And yung sa comorbidities, kailangan alam ng mga pasyente natin yung kanilang blood pressure. Yan. So, sabi ko, di ba? Blood pressure. Sana meron silang sariling blood pressure machine sa bahay. Kahit yung sa wrist, pwede na yun, no? Pero sana ay calibrated din ito. Kung hindi makabili ng sarili, magpa-BP sa ating pinakamalapit na health center or sa kapitbahay natin na nurse. Ang blood sugar at cholesterol, i-check natin once a year. And of course, para sa mga abnormal ang result, more often ang follow-up ng check nito. If more than 50 years old, hindi routine, pero some literature recommend checking the bone density using a bone DEXA scan. Okay? For age more than 40, for male patients, please make sure you include the prostate in checking. You can do a PSA blood test po iyon, or you can do your digital rectal exam. If may cancer sa family, yung screening advice natin for cancer differs per age. So pag meron tayong direct colon cancer sa family natin, age 50 or earlier, kailangan na mag-colonoscopy. And kapag parents mo or kapatid mo meron, is 40, even at 40. Pag breast, annual self-breast exam sa mga babae, that's a must. And then yung annual mammogram or breast ultrasound is recommended from age 50 to 74. Pap smear sa mga kababaihan natin is annual also, starting at age 30. And anal pap, depende. Anal pap kasi walang gumagawa sa Pilipinas nun, kundi si Dr. Roman, no, ng RITM, at hindi na pa niya ginagawa yata ngayon. Pero at least baseline ang sabi ng literature, no, because of the risk of anal cancer among those with anal warts. Okay. For drug interactions, there's this tool that I hope by now we are all using, na may app din siya, so i-download nyo din. Ito siya, yung Liverpool HIV Drug Interaction Checker. It's super user-friendly. Please use them. Etong ang classic example. Ang simvastatin ay ang pinaka-common na cholesterol medication na pinaprescribe ngayon. Pero alam mo ba na hindi mo siya pwedeng ibigay sa isang taong naka-lopinavir, ritonavir, no? Bawal siyang i-take. So, yung mga ganyang basic na drug interactions dapat ay alam natin, or kung hindi tayo sure, please use this tool. Okay. Another issue in the aging population is neurocognitive dysfunction. It is important for us providers to be able to screen our patients with this, and I'll show you later a video clip on how you can screen it. The neurocognitive dysfunction may be a cause of poor adherence, and therefore it will lead us to provide the following methods of support. Specific neurocognitive dysfunction is called HAND, no? Stands for HIV-associated neurocognitive disorder. It is defined as difficulty with memory, attention, speed of information processing, and executive and motor functions. It affects up to 30% of PLHIV on ART in the United States. Pero na-discover nila sa Pilipinas, mas mataas pa pala ang prevalence of HAND dito sa atin. So, I don't know if you guys are screening your patients for this, or if you know whether your patients have HAND, but it's something worthwhile to look at given na ang taas ng prevalence natin. So HAND will result in lower adherence, lower retention, heightened risk of mood disorders, including anxiety and depression. So let me just share with you, one sec. Share with you this short video that we have for HAND. Okay.
So what do you actually ask in your patient encounter? The best things to ask for are, do you experience memory loss? Makakalimutin ba kayo sa mga events, sa mga nangyari recently, sa mga appointment nyo, kung anong date na ngayon? Or do you feel that you are slower when you are reasoning, planning activities, or solving problems? Napakabagal nyo ba mag-isip or nahirapan mag-concentrate? Do you have difficulties paying attention in a conversation? Can you complete a book, or can you actually complete watching a movie? And basically, may problema ba? Do you have problems in handling money, in keeping track of your medications, in traveling, using public transportation from place to place, and even using the telephone or the cell phone? Those are very good questions to ask for you to be able to peg what is their actual functionality. So treatment, this is very sad because we don't have exact treatments for it. No? So I think we could focus more on the patients who are still asymptomatic, or only those who are mildly impaired. No? We can ask them to build up their cognitive reserve. No? all words, no, cognitive reserve. Liken your brain and your neuronal synapses to a tree. So there on the left, I have a tree with very few stems and branches, and on the right, I have a very healthy tree. So that's what we want to do. No, that's what we want our brain to become. We want it a very we want it to become a very organized and tree with all the leaves and all the branches. How can you do this? You have to exercise. So you have to tell your patient there is no excuse not to exercise. Exercise makes the blood flow and it brings substances to your brain, and it also flushes out toxins from your brain. No? Even if they have a significant amount of illness or debilitation, there are still things that they can do to increase their level of activity. And aside from physical activity or exercise, they can also engage in healthy conversation and learning activities. They may be online or they can be with healthy chats with family and friends. This cognitive reserve is what you need so that when the brain starts deteriorating because of neuroinflammation and viral infection, then you have things to fall, parang you have reserve. Other ways to improve cognitive reserve include playing a musical instrument, having games, board games, or other games with friends. You can have pets. You can talk to them. You can interact with other pet owners. And daily walks are very, very important. And you should always be open to new learning. Being open to new learning is something that is what we call a lifelong learning activity, and it will really improve your cognitive reserve.
Okay, thank you. Credits to Dr. Michelle Anlacan of PGH Neurology for sharing with us that lecture. Okay. Isa pa sa mga issues ng elderly aging population is a decrease in sexual drive. Again, multifactorial po ang influences ng sexuality in among PLHIV, and it's the following, no? HIV-related organic factors such as yung effect ng mga comorbids tulad ng high blood. So ito mismong natural aging and comorbidities, may effect yan sa sexual drive. Pangalawa, HIV-related psychosexological issues such as yung takot ng isang PLHIV na mahawa ang partner niya, ang hindi pag-disclose or ang pag-disclose ng HIV sa kanyang partner, stigma, and body image changes. No? Kapag meron siyang effects ng gamot niya, gaya ng lipodystrophy, baka hindi masyadong maganda ang tingin niya sa sarili niyang body image. Pangatlo, meron tayong MSM-related psychosexological issues gaya ng gay culture, self-perceived body image importance in gay culture, importance of sexual performance, anal sex, casual sex and group sex, and chemsex or recreational drug use. And lastly, HIV-related sexual behavioral issues such as ang pag-obliga ng iba ng paggamit ng condom, which can affect your sexual performance. So it is the interaction of all these factors which can lead to the demise of an aging PLHIV sexual drive. So anong gagawin, no? Ito yung mga sex issues ng aging PLHIV. Majority of those who complain of erectile dysfunction are over 70 years old. Pero nakakagulat din makita na 50% of those over 40, more than 50%, are already complaining of erectile dysfunction. So it happens earlier in PLHIV. And again, it is multifactorial. So meron tayong organic, okay, sa katawan, and psychological. Of course, when you combine it, kasama ng gamot, effect ng katawan, kung ano ng mga nararamdaman ng tao, ay it will lead to erectile dysfunction. Ito yung recommended algorithm natin sa ating mga provider on how to address the sexual dysfunction of our clients. So, mayroon tayong dapat na gawing screening through interview and questionnaires. And kapag na-confirm natin na sexual dysfunction nga siya, maaari tayong magkonsulta sa isang andrologist or endocrinologist. Sa endocrinology naman, kapag na-refer na natin, so kumbaga sa atin, ang basic natin na kailangan gawin is i-screen. So, tanungin natin ang mga sarili, do I screen my patients on sexual dysfunction? Isa lang itong interview at questionnaire. So, maghahanap ako ng magandang questionnaire, share natin sa inyo para mapasok nyo yun sa inyong mga must-ask during the annual visit. Sa endocrinologist office, magpapatest siya ng mga hormones, examinin niya kung meron bang mga abnormalities doon, and bibigyan siya ng preferred treatment. Okay. So, one more thing. How many more topics do I have? 2 more topics. One more thing that the aging population might be concerned with and you should be ready to provide information for is planning for their future. Number 1 is healthcare utilization. Meron ba siyang medical insurance? Meron ba siyang social assistance na makukuha mula sa SSS, DSWD, etc. Ang ART, huwag itigil. So, maliban sa libre ito, madali na siyang i-take ngayon kasi 1 pill a day na lang siya para sa karamihan. Pero habang tumatanda ka, yung adherence mo dapat nandun pa din. Make sure lang na mayroon tayong access. Patients who are older might find it more difficult in the future, we're talking about elderly aging. In the future, marami na silang mga barriers in going to you more frequently. So you should think of ways to make it easier for them, no? Sometimes difficulty ambulating or walking, walang makasama, takot lumabas ng bahay, or whatever reason, gawa tayo ng way para ibigay yung gamot sa kanila. Make it accessible. Pangalawa, they might need to talk to you about living will, advance directives in case they die in the hospital, on healthcare proxy. And then lastly is long-term care. Wala pa tayo doon, guys. Pero ito na yung panahon para magplano. Kasi hindi naman mabilis yan di ba? Meron ba tayong home for the aged? Yung mga pasyente natin ngayon na nabubuhay mag-isa, dahil walang pamilya or sa kasamaang palad ay tinakwil ng pamilya, nabubuhay na mag-isa, saan sila pupunta kapag sila ay 70 years old na? Meron ba tayong bahay na pwede silang pagstayan? Meron ba tayong long-term care facility for them? Yun. So, this is a systemic issue na kailangan pag-isipan ngayon pa lang. Pero sana'y huwag tayong abutin na ang dami nating pasyente in this age group and wala tayong anything for them, no? So, as early as now, let's plan. So, just a little bit of tip. Hindi ko alam kung uso ba to sa atin dito sa Pilipinas, ang advance directives, no? Ito yung, ngayon pa lang, habang ikaw ay nasa tamang ipag-iisip, and you're able to validate with your personal lawyer, is you wanna plan what happens when you die. Okay? So, gusto mo ba na ang gagawa ng desisyon, not when you die, rather, when you are, say, comatose, or pag tumigil ang puso mo, pag nasa ospital ka, gusto mo ba na meron ka ng nakalatag na desisyon? O gusto mo na sa panahong nagmamadali ang mga doktor para i-CPR ka, maratel yung mga kasamahan mo na nagbabantay sa'yo. Diba? Pero kung meron ka ng DNR, and this is, I think, very common among cancer patients, no? Meron silang DNR na kapag tumigil ang aking tibok ng puso ay hindi ko na gusto ng any extraordinary measures. And that's included in their hospital record. Dala ito ng kanilang next of kin or kung sino man yung health proxy nila. It's a hard conversation to have with your patient, but might come up. So I think you might want to read up on how to select advance directives and maybe to assign a healthcare proxy. So I've been successful in some of my more mature patients wherein they have legally acknowledged healthcare proxies na magbibigay ng desisyon during the time na sila ay nasa ospital. So ito rin example ng proxy consent or healthcare medical power of attorney. Okay? And then sample din to ng living will. Okay? I-upload naman tong mga slides sa ating drive so pwede nyong i-analyze, no, when that happens. And lastly, last topic. Okay. Ang long-term survivors ay ang isang subpopulation ng PLHIV who have been diagnosed before meds were available. So before 1996. And they make up 25% of all people living with HIV, and this includes children with HIV who acquired the virus as babies and are now in their 30s and 40s. So sila ay mga PLHIV for over 25 years, and some of them have what we call long-term survivor syndrome. Okay? So FYI lang, June 5 is HIV Long-Term Survivors Awareness Day. Hindi ko alam kung worldwide ba ito, pero sa US ito. And gusto ko lang mag-share sa inyo ng isang video clip featuring long-term survivors.
The worst thing in those days was the continual drumbeat of death.
People were just dying all around us.
It just seemed like my whole existence was being wiped out.
As an HIV positive man, I just knew that I would be next.
I'm an AIDS long-term survivor.
I'm an AIDS long-term survivor.
I am an AIDS long-term survivor.
The worst of the AIDS epidemic was in the 80s and the 90s.
I went to a lot of memorials, a lot of tears.
I lost friends, lovers, family, you name it.
I literally froze in my own place for the fear that I would be next.
I fully expected to be dead.
I actually felt dying would have been the easiest thing to do, because then you wouldn't have to watch everybody dying.
In 1996, protease inhibitors came along and changed the game. People stopped dying in such huge numbers.
It's kind of this very mixed feeling.
It sounds like it should be one of those, oh, be grateful, have a party, you're gonna live. It was the exact opposite. It sent me into a tailspin.
I had huge amount of depression that I had to deal with.
Living through the last 34 years and losing everyone, I don't even know how to articulate how painful that is.
You cannot watch that many people die. You cannot watch the injustice that we watched and not have that affect you.
Once the worst of AIDS was over, things subsided, people were moving on with their lives, though that moving on was difficult for a lot of us.
AIDS survivor syndrome is a continuing sense of being caught in the death horizon.
46 to 48% of us deal with depression, suicidal thoughts and tendencies,
Anxiety, lack of future orientation, not being able to imagine being an old person.
The cause of AIDS survivor syndrome is multifaceted. It is physical, because of the chemicals that are in my body. It is psychological, because of mourning and loss and what I've gone through emotionally. And it is environmental, as I feel that my experience is being erased from the public record within my own lifetime.
Society in general, when the medications came, shelved us all. They wanted us to shut up and go away.
The answer to AIDS survivor syndrome is let's kick ass.
Let's Kick Ass stands for Let's Kick AIDS Survivors Syndrome.
We're a grassroots movement of long-term survivors, both positive and negative, dedicated to ending isolation, reclaiming our lives, and imagining the future we never dreamed of.
When I found Let's Kick Ass, I felt this intense sense of relief.
It was like a bolt of light in an isolated darkness for me.
It's ended my depression, my anxiety, and my sleep disorder.
Let's Kick Ass has enabled my heart to open again in a way it had been really shut down for years.
It's actually given me a life in a community and love and things that if I start talking about too much, I'll tear up.
We are warriors.
We are warriors.
We are warriors.
We are warriors.
Let's kick ass.
Let's kick ass.
Let's kick ass.
Okay, and that brings me to the end of my talk. Meron po tayong isang organization of aging PLHIV in the Philippines. It's called PELP, or Positive Elders Philippines, Inc. Nawa ay mabigyan din natin sila ng presence, ma-recognize natin sila dahil sila din ay part ng ating HIV family. And thank you, everybody. Nga pala yung lugar doon sa video is the AIDS Memorial Grove in San Francisco. If ever you're in the area, I strongly advise you to go there. No, it's in the Golden Gate Park. Sobrang peaceful, sobrang magical, and nawa ay ma-bucket list nating lahat yun. Thank you.
Okay, maraming salamat. Sorry. Maraming salamat to Doc Kate. Again, we are now opening the floor para po sa inyong mga questions tungkol ho sa naging discussion ni Doc Kate, which is aging. Okay pa? Sige po. Sino po ang nagnanais na unang magtanong po sa ating Doc Kate? Yan. Tanong lang po, raise lang po ng kamay, tapos paki-unmute at kung kaya ko niyang i-open ng yung camera, ay go ahead po. Sige po. Questions?
Yay, walang question.
Meron ho. Ayan. Si Ma'am Nimshi, sige po, paki-unmute po and ask the question po. Go ahead, Ma'am Nimshi.
Hello, good morning po.
Hi, ma'am.
Adra, more on, i-share ko lang yung hindi po question kasi ang pinakamatanda namin is 62 years old. Pero totoo po yung sinabi nyo, hindi. Anyway, 3 years lang siya sa akin nagstay kasi po namatay rin siya pero hindi po sa AIDS-related disease. More on parang yung hereditary hematologic disorder yung nangyari sa kanya. So, ano po kasi siya, undetectable na. 2 years na undetectable. Third years, parang nag-deteriorate siya. Mataas ang CD4, virally suppressed talaga. Pero hindi naman natin din makokontrol yung mga yung sakit na nangyari sa kanya. Nalulungkot lang ako kasi very supportive yung family niya and then ganun po ang nangyari. So, ang susunod po naming matanda is, I think, 53 years old. Na kaya siya naman po ay diabetic. Nag-MI na po yan na ICU ng 1 week. Hypertensive, pero ngayon up and about at saka binarily suppressed na rin po siya.
Ma'am Nimshi, thank you for sharing. No, malungkot tayo na narinig na namatay yung patient mo na